As I begin this presentation, it's really relevant for me to acknowledge the work of the people who've participated in the Canadian Home TPN Registry, particularly Bianca Arendt, who's worked in Joanne Allard's lab for many, many years, and Joanne Allard herself, who's been a big driver of the Home TPN Registry, and she should be doing this but can't be here today. Alberta puts in a lot of the data, so I'm slightly legit. You guys also need to know that the Canadian Society for Clinical Nutrition, which was one of the founding organizations of CNS, started with the Home TPN Registry with the support of CALIA. So this actually relates to the history of the Canadian Nutrition Society, so it's really nice to be able to bring it back to you today. I've got some disclosures, and I have four learning objectives, but Kelly's actually covered off quite a few of them, and so I'm going to take a focus. So let's talk about home TPN programs in Canada, talk about results from our home TPN registry, and talk about how we're advancing care. And it's really appropriate for you in this audience to think about the data that Kelly has shared with us and think about how we might optimize intestinal health in those patients who have intestinal failure. Kelly's defined this nicely, quick blurb. Definition of a short gut is malabsorptive syndrome that results from extensive intestinal resection, but I actually like the definition of intestinal failure. It sounds like renal failure. And when you're a gastroenterologist in the game of intestinal failure, people don't really get it. It's a rare disease. So I like to use the example that intestinal failure is to home TPN what kidney failure is to dialysis. You need life-sustaining solution provided by an intravenous line that is your lifeline. It's end-stage organ disease requiring support. Kelly's really nicely elucidated the short gut implications, nutrient malabsorption, water and electrolyte malabsorption, site-specific transport function, loss of site-specific endocrine cells, and loss of ileocecal valve. I like the way that she's focused on the role of salt and water absorption that's impacted by GLP-2, and I want you to think about that as we go forward. Just a little bit of background. Well, how common is intestinal failure in Canada? This slide's a few years old, but 6 years ago there were estimated 400 patients with intestinal failure in Canada, and that's based on data largely from CALIA, who's a major home PN provider in Canada. There's only a few of them. Home PN, life-sustaining therapy for patients with intestinal failure, is provided in our country through really specific programs. Very different than the US and Europe, where in US infusion companies might be providing home PN with practitioners that may or may not have expertise in the provision of that care, but we have specific home PN-based programs. And the amount of support, the type of support we have for those patients with intestinal failure varies. So for instance, whereas people on dialysis are involved in Alberta, the Northern Alberta Renal Program and the Southern Alberta Renal Program, where kidney failure affects 400 Northern Alberta patients, this is a rare disease. And it's costly, and it's associated with poor outcome and poor quality of life. So if you look internationally and think about what the prevalence of intestinal failure is, it actually varies a lot if you base it on data related to home PN utilization. Some countries, provinces have more or less home PN utilization, so it's really hard to get a handle on this. So for instance, in Spain, 0.65 patients per million. In the US, 120 patients per million. Canada at this time, 18 to 48 patients per million. So if you look at the variable geographic utilization of home PN as a marker of intestinal failure, you realize that as clinicians, we're applying therapies probably inconsistently, because I don't like to hypothesize that the prevalence of vascular injury or inflammatory bowel disease or surgical catastrophe impacting the development of that intestinal failure varies over geography. So David Armstrong, who's at MAC, who's one of our home PN registry founders, did a study last year, survey, and essentially he was trying to justify home PN in his province because they were facing a lot of challenges. So they looked at a variety of programs, and the programs across Canada vary in size from 25 to 70 patients, and that correlates to the 18 to 48 per million. Think about the variation in province population. There's a variety of supports that go along with each of these programs, from a low of 0.3 FTE of a nurse. Think about who needs to support home PN populations. You need them to teach how to use a central line with sterile technique. You need a good dietitian to write the appropriate PN prescription. You need good pharmacy support or home care delivery support, and you need a doc to oversee it. That's one of the prerequisites for Canadian home PN programs. You need a physician who's got expertise in the area to provide that support. And so there's variable coverage and skill mix because, for instance, John was telling me they have a home PN, they can discharge patients on home PN from Queens, but they don't have a home PN team. So a lot of variability, and probably the majority of home PN patients in Canada are involved in home parenteral nutrition programs. That 6.8 FTE per program is from Calgary, where home enteral nutrition is also included in their program. There's no funding, there's not a lot of room for docs, but docs lead these programs and provide good skill. And there's variable policies on wait lists, how we prioritize our patients. And we don't use PN really for the pre-op space, so that individual who's severely malnourished with SGFC and a BMI of 13 who needs a small bowel resection for severe Crohn's, we aren't putting those patients on home PN. There's also marked variations in funding and processes as it relates to the hospital, region, or province. And in fact, at that time, David didn't collect data on indications, duration, admission, but more on that coming to you. So many years ago, in 2004, we started the Canadian Home TPN Registry. And we did have a specific objective at that time, and it was to prospectively collect data on Canadian home TPN patients with involved and participating programs. We looked at demographics, survival, complications, whether or not patients had PN dependency, and we also wanted to document home PN practices. When we initially started data collection with the Home PN Registry in 2004, we had 4 founding programs, and at that time, you got into the Home PN Registry if you'd already been on Home PN for 2 years. So you didn't get in the Home PN Registry at that first kick at the can if you'd been on Home PN for less than 2 years. Think about the messing slide that Kelly showed us. Once you've been on Home PN for 2 years, the likelihood of permanent PN dependency is exceedingly high. So these were patients who we knew had long-standing chronic intestinal failure. And our intent was to capture data every 1 to 2 years on all patients so that we could get a snapshot over time. So the initial programs included Scott Whitaker's in BC, a large program, the Northern Alberta program, David Armstrong, Hamilton, Cush in St. Mike's, and Joanne at the University Health Network. In 2014, there are multiple programs contributing data. Once again, pediatrics is not involved in the registry. You can see that now in Alberta, both Edmonton and Calgary include data. Regina has a small program, but they don't include data in the registry. Ottawa and Quebec City and London have a home PN program but don't include data in the registry. Halifax has some home PN but don't include data in the registry. But you're seeing that there's a Canadian landscape to this with centralization of care in centers where there is expertise. Early on, when we started this in 2004, there was some clear issues from a real clinical perspective that were raising their head. What type of catheters were we using? Single lumens, double lumens? What was our infection rate for catheters? Did it relate to the number of lumens you had? Our prevalence of liver dysfunction was actually quite high, and Maitri Raman published this in the Canadian Association of Gastroenterology journal. And if you had persistent abnormal liver function tests for over 4 months, you were categorized as having liver dysfunction. Think of how we were doing data capture, and that was present in over a quarter of patients. We were doing liver biopsies in patients with abnormal liver function tests about a third of the time. So what we also found out in this process is that people participating in the program, it leveled the playing field. You wanted to be kind of the same. You wanted to know how to advance care. You were talking to other experts in the field so that you could really optimize care. It was clear early on also that abnormal liver function tests were associated with dextrose dosing. 2/3 of patients were hospitalized in that first snapshot, and within those 2/3 of patients, half of them had a PN-related complication. At that time, our thinking was 2004, people die of their underlying disease that caused the intestinal failure in the first place, but we're getting a lot of signals that home PN was associated with lots of morbidity. We did bone density studies in about 2/3 of patients, and a lot of them had osteoporosis or osteopenia, bone disease associated with malabsorption. And we used crude markers for quality of life. So our Karnofsky Performance Score is an objective marker of functional status. So a KPS of 65 means you can't vacuum, you maybe can get dressed on your own, you're certainly not cooking, you're not putting on makeup, you're not out walking every day. A KPS of 40 means you're moribund, you're lying in bed, can't do anything. So these patients were not very functional. And home PN, we didn't look at the impact of that. And early on, costs of home PN were about $60,000 to $100,000 per year. We haven't tracked that prospectively and don't follow it. Once again, funding, for instance, in Alberta, every province has a different funding mechanism. In Alberta, we have provincial funding. We've never been tapped for funding. In Ontario, they're tapped. They have to cap programs, they have to meter in registration, and what it does is keep patients in hospital longer. So let me give you a brief update, and this was provided to us last year and hasn't been updated further. With our initial data collection, and each site who is a member of the Home TPN Registry puts in their own data every year or every 2 years, we can access our own registry. And one of our fellows, Paula from Thailand, has a poster out there who's recently looked at bone disease and fracture risk relative to vitamin D in home PN patients. So at the first kick at the can, we had 257 patients, and each year we've aggregated more patients, and you can see what's happening is that we're following patients over a longer and longer period of time as they've been on home PN. We've got a total of, and this was based on mid last year, 831 patients in the registry. We're CHA, so we actually have a superb dietitian, and it is our superb dietitian in the program who methodically includes absolutely everyone we have on home PN in the registry. Our current program in Edmonton, the second program there, we have about 70 patients, 5 pediatric patients, 65 adult patients in our program, just to give you a sense. So where there are adult programs, there's usually a pediatric home PN program. Pediatric intestinal failure is a unique beast, but the consideration of expert teams is very relevant, and the expectation that you have an expert team, multidisciplinary, including patients, participants from across disciplines. Other programs, BC, Foothills, Hamilton Health Sciences, Manitoba, St. Mike's, and Toronto. These were all blinded initially, but we all talk to each other, so we can see what variations in practice are. And I remember the first time we saw the registry data, we had the highest infection rate. I was thinking, OMG, what are we going to do? And we had a discussion at the meeting, and it turned out we were capturing data in a slightly different way. But this is a really good way to do peer review and quality improvement based on a comparison with other like programs. So if you look at the indication for home PN and fairly well-established long-running home PN programs, because Cush started the first home PN program probably in the world, probably 100 years ago, and we think about indications for home PN that might be amenable to intestinal rehabilitation, you can see that the leading indication is short gut. That means you simply do not have enough bowel to absorb nutrients required to sustain life, whether it's from vascular trauma or multiple surgical resections. Mucosal defects, relatively infrequent. Motility disorder, probably not a disorder that might be amenable to treatment with GLP-2 analogs, 10% of the population. In 2013, fully 25% of patients had cancer. Once again, not a group of patients that might be amenable to intestinal rehab, where that's not your goal of therapy, but an appropriate group of patients to study and provide support with. Surgical complications, those are patients with multiple intracutaneous fistulas just not healing, open abdomen, living at home with really poor quality of life, pancreatic disease, relatively infrequent, and other indications relatively infrequent. Our vascular access has been bone of contention. Think about that first slide I showed you, 50% of patients in hospital. Those hospitalizations were largely due to central line-related infections. And our practice has changed over time, and I'll show you a slide related to that. So we're using, in 2014, primarily peripherally inserted central catheters, and it varies across sites. We're also using tunneled Broviac catheters. We leave our PICC lines in for up to 12 to 18 months. Some patients prefer it. We teach them how to use a PICC, and in fact, in the individual who's really thin to start with, BMI less than 18, you're worried about a pneumothorax, we might start with a PICC line and then transition over to a more tunneled catheter. You can see that we have a variety of patients with single lumen catheters, but most patients have 2 lumens. And our pattern of practice in Edmonton is try and use as least lumens possible. More lumens means more areas that can become infected. Although we haven't shown that, we haven't actually proven that. So one of the questions that we asked ourselves last year is, has there been a change in characteristics over time? Because we've been working together as a group over a period of about 10 years now. And so what we did is we looked at baseline entries, patients who started at baseline between 0 and 24 months, and then we looked at and compared between 2008, 2009 to 2011, and 2012. And this is really work that Bianca has spearheaded with Joanne's direction. And we included patients who are currently on TPN. What I want you to look at is that in the first bar you can see that overall, how people get off home TPN hasn't really changed. We can see that most patients die to get off home TPN. About a third of patients are weaned off home TPN, and that hasn't really changed between 2008 and 2012. There are 2 transplant programs in Alberta, in Canada, Toronto and Edmonton, largely dealing with pediatric transplantation, but we've had 11 transplants in Alberta. None in the past couple of years. People also die of non-TPN complications. You can see the prevalence hasn't changed too much. If we look at PN characteristics, and this will give you an idea of what the type of patients we're taking care of. Average age is 55. Half to 2/3 are female. And these patients have been on TPN for a long time. 8 years, 10 years. So the ones that are being reported more recently, of course, they're on TPN for a shorter period of time, but we have a large cohort of patients who've been living with intestinal failure for a long, long time. The indication has changed over time. So when we first started this, and that was about the time that we started using home PN in advanced cancer in Alberta, or shortly thereafter, you can see that although the prevalence of cancer as a diagnosis is not statistically increasing, the prevalence of short gut has decreased over time. Less mucosal defects, less motility disorders. Surgical complications kind of going up. One of the things we see in Alberta is that in the patients with the toxic concrete abdomen with multiple intracutaneous fistulas, we're sending home for 12, 24 months to decrease the hostility in that abdomen, to allow an optimal period of time for the surgeon to go back in and consider surgical recorrection. So with really good teams, we're identifying these patients as inpatients, saying, okay, let's get them out of the hands of the surgeons. Let's let them go home and recover and acquire mental and physical well-being before we subject them to that. So indications for home PN changing over time in this cohort. We're using more PICCs now than we are previously. Really readily available vascular access, safe. Some patients actually prefer them. In the summertime, you have a thing hanging out, which is a problem for some patients, but other patients really like that type of vascular access. You think, gee, how can I hook it up? But they have extensors, and our nurses teach them how to use a PICC access. And what we try and do is choose a vascular access method that individuals prefer. We do not like implanted catheters, but you can see that the prevalence of use of those subcutaneous catheters, which we've had some real trouble with, is relatively low, 10%. We leave vascular access at our site. One of the things we've learned about 10, 15 years ago, we used to have whoever the surgeon on call was putting in our vascular access, and it was problematic. It would be the last case of the day. They might not be the best vascular access person, and so 2 of the interventional radiologists lived behind me, and so we went and took them for lunch, and we said, interventional radiology, you're now our vascular access kings. It's been a really important advance in care of our patients because we have a dedicated interventional radiologist who give us just-in-time access, who are really responsive to the patient's needs, and they're doing it according to their time schedule. So I think that represents an advance in care and potentially might be contributing to our reduction in infection rates. Let's give you a picture of nutrition. I want you guys to be thinking about the data that Kelly shared with us in the teduglutide work. Reducing volume by 3 liters a day is about 700 cc, 3 liters a week, pardon me, is about 700 cc's a day. Didn't consider nutrient requirements or absorption. So what you can see from this slide is that our patients have a BMI of 20, hasn't changed over time, but it goes up. We don't have recent BMIs, so people gain weight on home PN, that's not a surprise. We typically give them between 1,800 calories per day. That hasn't changed over time. Our patients are truly energy and protein dependent in their PN admixture. So for instance, 90% of the calories and protein that patients require are being provided from PN, and similarly a vast majority of their protein requirements. They're taking in about 500 to 1,000 calories orally a day. So these are patients with true gut failure, but you can see they're not eating a lot. Is that an opportunity for us to try and advance care? Does it relate to high ostomy outputs? Does it relate to poor appetite and their gut microbiome and other signals to appetite? We certainly have short gut syndrome patients who get 50% of their calories from PN and eat 3,000 to 5,000 calories a day, those hyperphagic intestinal failure patients. But that probably, based on this data, obviously is the minority. And they're not eating a lot of protein orally. 3/4 of our patients have oral intake, and we have relatively few with enteral intake in addition to oral intake. So if we think about data change over time, has our practice changed? You can see that although the range is from 0 to 7 and 0 to 2, there's actually been a significant reduction in hospitalizations and days in hospital over time in this cohort of 800 patients that we've followed serially over 8 to 10 years. No change in number of lumens, but we're also seeing reduction in line infections per year. I don't think, we've actually had the same nurses in our home TPN program for about the 20 years that I've been in the program, and I don't think their teaching technique has changed. I actually think it has to do with the time of line insertion. If we think about reducing catheter-related bloodstream infections, that probably makes sense, and the fact that we've got a standard DI approach for that. We're also seeing less changes in vascular access over time, certainly contributing to a reduction in morbidity for our patients. We're correcting and changing catheters. Just to give you a sense, we have one patient who's had the same central line for 18 years. No trouble. So there are really good patients. We also have patients who have had 6 line infections in a year, and we're starting to be more proactive with respect to being aggressive, using ethanol-containing locks, using antimicrobial-containing locks, and we do that by talking across the country. Hey, what do you do? What do you do with your patients who are frequent flyers? So we have a lot of crosstalk across the country. And interestingly, Kush continues to be a leader. He is always pushing the envelope forward. So if we look at the same data, proportion of patients with line sepsis in the preceding 12 months has reduced significantly. If we compare the first period of home PN data aggregation to the most current data aggregation. What about liver function tests? Don't know why or how. You think we haven't changed our energy provision, haven't changed our protein provision, but we're seeing reduction in liver function test abnormalities. Is that because we have less line infections? Possibly. We're not seeing the same degree of advanced liver disease that I used to see 20 years ago. I'm not seeing PN-associated liver disease that kills people unless they're in the hospital really sick for like years on end with intra-abdominal sepsis. So it seems to be less of an issue. We have a new registry for the home TPN, a new database as well as new public website. And one of the other recent advances is the development of the short bowel syndrome of Canada Society that's led by a patient of Kush-Gigi boys, and that's being incorporated where you've got, now it's not a section of the Oli Foundation because you have to be American to do that, so it becomes a real bonus for our patients, and we're just in the process of developing a board of directors to be a place to go for patients in Canada that extends beyond the program in Toronto. Joanne, Olivia, Brian, leading programs. The people that we know every day are helping patients advocate for this, but it's the husband of a patient who is on home TPN that really got this ball rolling. So it's a way to provide a voice to our patients. So if we think of home PN in Canada and consider opportunities, we actually think that there's a role to develop a position statement. I don't know, Kelly, you probably talk about short bowel syndrome across the world, and I suspect that our environment, our population, our aggregation of expert care is unique, and we think that we need to create standards. For patients, John, like yours, where you don't have a home PN program, what do we need to do? What we also need to do is be aware of the indications and expected numbers, because for programs like David Armstrong's at McMaster, where they have access issues, they can't discharge discharge patients from hospital, the absence of access to home PN is contributing to increased length of stays and hospital-related morbidity and mortality for those patients who we think are going to have more permanent intestinal failure. We need to be able to advocate for that. We've never had a ceiling in Alberta, but we need to be able to advocate nationally for adequate support for these patients. Team composition is relevant, and so in our program we deal with both adults and pediatrics, and our numbers have gone up. When I started the program 23 years ago, or joined the program, we had 5 patients. We're now at 65 with 5 to 7 pediatric patients, and we've grown. So we have ready access. It's not a barrier. We're finding a big area of growth is home PN and advanced cancer, and it contributes significantly to quality and quantity of life in a particular cohort of patients, and we need to support that. We need to probably better with follow-up strategies. So Sarah recently has developed standards for our program related to more proactive strategies for iron repletion, vitamin D repletion, so that these happen without us having to think about it. We have an incredible, stellar home TPN dietitian who's usually in front of things, but having standard processes to monitor bone disease, to monitor iron nutriture, because iron is not typically included in home PN, and to think about vitamin D status is probably really relevant. And we need to be cognizant of concurrent care. I'm aware of the fact that we haven't addressed the quality of life issues. And you're right, Kelly. I didn't point out that the average number of days on home PN in our programs is 6 days a week. So all of us are working really diligently to give patients date night, a day off. And we do that if they have an energy requirement, if they maintain their weight, and you back off. If they don't, you put a few extra calories and a bit more protein in the other 6 days of the week. So it's something that we shoot for, and we try to reduce at all possible the amount of PN and the burden, the nighttime burden. So for instance, when someone's hooked up to PN for a night, they're up to pee 3 or 4 times, the thing's beeping off. It really has a negative impact on quality of life, and we don't tap into that. We all know our home PN patients, even as the programs get larger, and they are valiant, graceful survivors by and large, because it's rare disease. No one knows about it. Kidney failure, oh yeah, you're on dialysis. I get that. I know a friend who's on that. But home PN, people don't understand it. Actually, in our program, we have 2 patients on home PN and dialysis, and they do it unblinkingly, without hesitation. Admirable, graceful patients. We need to be focused on these patient-centered outcomes, and there's probably room to develop some patient and family satisfaction surveys, as well as potentially a global rating score for efficacy, efficiency, effectiveness, and quality, safety aspects of home PN care. And that's all I have to say. Thanks.